Welcome back to another student physical therapist video. In this video, we are going to cover differential diagnosis of lateral hip pain. And this is going to be a slightly shorter lecture, and we're going to spend more time on the anatomy portion of it because the things I want you to see are of these six main causes of lateral hip pain, hip osteoarthritis and referred pain sort of have the slightly different, well, actually mainly referred pain has the slightly different management. But if you look at the third tier of each one of these on the lateral hip pain mind map, with the management of each one, you can see that they're almost identical. And that goes back to we need to treat the symptoms and treat the individual person's symptoms that they're coming in for, because almost every one of these things has very similar treatment. So if we look at the six main causes are trochanteric bursitis, gluteal tendinopathy, IT band syndrome proximally, because typically we think of IT band syndrome more distal on the lateral aspect of the knee, hip osteoarthritis, referred pain, and then muscle strains. And of those two, I mean, we're going to treat a muscle strain fairly similar. I mean, maybe we're going to use some different loading principles as gluteal tendinopathy, but a muscle strain and gluteal tendinopathy are similar. The trochanteric bursa is just the layer that's just underneath that. So all these things, that regional anatomy is so close together in the lateral hip that we need to treat the individual person, and then we need to treat their impairments that they're coming in with, which is largely going to come from the physical exam. But me personally, when someone comes in, I want to know what movements aggravate their symptoms, and that will cue me in to what tissue is aggravated. So then I can try to determine if it's more the bursa versus a tendinopathy. But honestly, it doesn't matter a whole bunch to me because we're going to be treating those symptoms. So let's say they have limited hip extension mobility. So we're going to have to work on opening up the quads. If they have extensor weakness, glute med and glute min and glute max weakness, we need to treat that. And then by means of treating those impairments, then we're going to take pressure off of and alleviate the symptoms so that we can build a more robust person. Let's look at the management of each of these individually, and then we'll look at the anatomy afterwards. So with trochanteric bursitis, let's start with all of these. With all of them, you can see that we have the common themes of gradual load progression, eccentric abduction strengthening primarily, or strengthening of the hip abductors and the hip extensors, mobilization and manipulation. So for all of these, there's good evidence that you want to use manual therapy plus exercise combined. And that combined treatment approach, that with activity modification and patient education are sort of like our bread and butter treatment for all of these. I mean, you can kind of extrapolate that to the entire body, that we need to use manual therapy plus exercise, and then we need to use activity modification and patient education. You can see how those buckets are very similar. So on the treatment side, exercise, manual therapy, manipulative therapy, and then on the education side, that's how are they going to modify their lifestyle to get better. For each one of these, for trochanteric bursitis, eccentric abduction strengthening, mobilizations and manipulation, what mobilizations and manipulations are you going to do? Well, you're going to find what ranges of motion are restricted, and we're going to mobilize into those ranges. A lot of neuromuscular reeducation with the lateral hip, and especially when there's weakness in the outer glutes, there's a tendency to be imbalanced through the hip where that lateral hip is taking on too much stress and strain. So we need to strengthen the hip abductors and the hip extensors to hold the hip more in a more upright position. For many of these, for all hip conditions, I want to watch how the person walks too, because gait training is such a fundamental part of everyone's everyday life. They have to get up and move, and making sure that that they're not spending too much time on that leg, or they don't have a Trendelenburg or a compensated Trendelenburg pattern. I personally do a lot of mobility flexibility training with these individuals. Usually the lateral hip takes on more stress or strain because the anterior chain through the quads is often too tight, and then the low core on that side is too weak. What I mean by that is when the front of the hip gets too tight, it pulls the hip into more of an anterior to pelvic tilt position that shortens here, and then it puts a lot more stress and strain back through here. So if we can work on this position, staying strong through the core, because if this is tight, it pulls this into a lengthened position. So strengthening the core while opening up the hip and then making sure that the glutes are strong is a key pattern that I'm looking for with almost all lateral hip pain. As we work our way kind of from bottom to top on this chart, people might come in with slightly different presentation of symptoms. So they're going to have, with trochanteric bursitis, they're going to have pain with lying on that side or repetitive movements. Now with gluteal tendinopathy, they're going to have, because it's the glute, and the same with a muscle strain, if you contract that muscle and as the either in the muscle belly or as that muscle tapers down into a tendon, active abduction of the hip is going to cause pain. With many of these, you're going to see pain with weight bearing on one leg, because as they stand on that leg, if the lateral hip takes on too much stress or strain, it's going to cause a reproduction of their symptoms. The main difference of these 6 things is the referred pain category. And no matter what, when someone comes in with lateral hip pain, I'm going to be looking at the lumbar spine and I'm going to be looking at how their core is functioning. With referred pain, the 2 main criteria are, is it coming from the lumbar nerve root compression? So with the lateral hip, I'm thinking anywhere from L3 to L5 as those dermatomes wrap around the hip. And the other thing could be the neuralgia paresthetica, which is L3-4, and the lateral femoral cutaneous nerve, which pokes out sort of in the midway through the IT band. And that's a branch of the femoral nerve. With those, we're going to be looking at more of like a McKenzie extension sort of protocol if it's lumbar, if it's coming from the lumbar nerve roots. Again, strengthening the extensors, the hip abductors, core strength, and nerve glides if we need to, for the referred pain category. But where I want to spend the bulk of time on this video is then looking at the anatomy and the association of these different structures. So we're going to take these from the layers of the bony structure, bone cartilage, connective tissue, and then we're going to work our way out. So with hip osteoarthritis, there's a degeneration of the cartilage that lines the hip, and that could be the acetabular cartilage, or it can be over the femoral head. But and this is going to be someone likely 45 to 65 years old or older, and we're going to see a limitation in hip flexion, and internal rotation primarily. Those people are going to have more symptoms early in the morning, and it gets better with movement or exercise. It's a degeneration of the actual cartilage and then wear and tear on the underlying bone with hip osteoarthritis. As we add layers of muscles on, you can see the first layer here, we have our iliacus, some of our adductor tendons. This is the psoas muscle as it comes down. It comes down to a common attachment point at the iliopsoas tendon. Here's our first layer of core, so our transverse abdominis. You can see how that goes down and attaches on the pelvis. So if someone has tightness on the anterior hip here, it's going to pull from our connection through the deep core. All right, we're adding the layers on. From a lateral hip pain, what muscle is this right here? That is going to be our glute minimus. So if someone comes in and they have pain with hip abduction, it might be the glute minimus, or it could be the glute medius, or it could be trochanteric bursitis. But with the glute minimus, we have the muscle belly of the glute min, and then that tapers down into the tendon as it attaches onto the femur. Let's isolate that muscle there. You can see this is the entire muscle of the glute minimus. The insertion is going to be on the greater trochanter of the femur, which is, as it contracts, it's going to pull that leg into hip abduction. Let's add on another layer here. Covering the glute minimus is the glute medius. Very similar insertion point over on the greater trochanter. Again, pain with hip abduction on this. So we see the relationship of the femoral head and neck to the various glute structures here. Glute medius, right underneath that is the glute minimus. The last layer here is we're going to see our glute max in the back, which has attachments on to the IT band. And then we also see when I say IT band, it's IT band and the distal portion of the TFL. Now you might ask, how does the IT band cause lateral hip pain? I view it more as the complex of the lateral structures of the leg. So down here is the actual IT band or iliotibial tract. That is a direct continuation of the TFL muscle. And our TFL is a flexor, abductor, and internal rotator of the hip. So if you raise your leg up and turn it in, you'll feel a lot of tension on the anterior hip, and that's the TFL muscle contracting. If there's too much tightness there or too much work happening in the TFL, these people will come in with a femoral internal rotated position. They'll say that it hurts on the front of their hip with squatting type of movements or with repetitive running type of motions. But it's this TFL attachment into the IT band where we can say that the IT band can cause lateral hip pain. But again, think about it more as the connection of the tensor fasciae lata as it connects up onto the ilium and then turns into the IT band. So we've looked at various causes of it. We looked at the anatomy of the hip joint. We talked about the glute med and glute minimus tendons. As we add on the connective tissue, you don't see a ton of connective tissue when I click that button. Let me take it away a few layers. If I add it on here, you can see that the dense ligamentous connection around the hip, which provides tons of stability. But then also here we have our deep trochanteric bursa and superficial trochanteric bursa. Because of the overlying anatomy, if there's too much friction or too much rubbing on the bursa, because of the muscular layers that surround it, that can create irritation in the bursa structure. You can see how closely related the anatomical structures are, which is why we need to treat the individual impairments that the person comes in with. And from a research-based standpoint, the strengthening, the mobilizations, making sure that there's flexibility in the hip, that's going to be synonymous for all causes of treating lateral hip pain. So in review, we have the TFL turning into the IT band. We have the glute minimus and the glute medius as potential causes of lateral hip pain. It can be the hip joint itself, or it can be caused from referral pain coming from the lumbar spine. So if we take away all the layers, many of the nerve roots as they pass around the lateral hip, you can have referred pain from the lumbar spine that then is contributing to one's cause of lateral hip pain. So that, without being too quick on this one, I think the main things I want you to see is that the regional anatomy is so closely linked together that don't worry too much about the underlying tissue that's involved. And again, treat more of the impairments that they're presenting with, because whether it be bursitis, tendinopathy, a muscle strain, IT band syndrome, or the hip joint itself, we need to treat the local impairments versus treating the specific anatomy that's involved. So I know it was a quicker lecture today on the differential diagnosis of lateral hip pain, but I hoped from an anatomy standpoint and a management and pain width standpoint that you learned a bit about each one of these categories.